Okay, so I started the recording, so we're good. And you know you're chatting to everybody.
Right. And I'm chatting in, welcome. So I thought I'd just put that up. And then after I read this on the CEUs, then I'll go ahead and just take that and put that over there.
Okay.
Sound good?
Yeah, works for me.
All right.
So then when you start, do you want me to mute the lines?
We've kept them open because that way, because we're trying to get people to interact.
Okay.
So we've kept them open during the webinars, but we have put the three of us, Pat and Priscilla and Martha, where we could just talk amongst ourselves before we get started. So I don't know if you know how to do that or not. But
well, I've already opened up the line, so I think everybody can hear.
Okay.
But the only other person on the phone is Boris, and he can listen in.
Good morning, Boris.
I don't know if he's paying attention.
Oh, here. Hi, Pat.
I don't think she's dialed in. I haven't seen her dial in yet.
Oh, can you see when we dial in?
Yeah.
Oh. Can you see what I'm doing right now?
No. That I cannot.
Well, I'm glad I put on my skirt today.
Yeah, I haven't seen her dial in yet, so I'm hoping that she's got the number. I would imagine so. You put it right there.
Well, it's right there, so she can, right there. All righty, dighty. Boris, say hi to me. He's not going to. Shutting me out, that Boris.
So do you guys normally have a big group for these?
We have been having probably anywhere from 10 to 20 people.
Oh, that's not bad.
Yeah. Do you think that's a big group or? So, yeah.
Hello.
Oh, Pat. Is that Pat?
Hi, Martha. How are you?
Good morning. I'm great. How are you?
Fabulous.
Good. Listen, we have our right-hand man today, or woman today, is Priscilla. Have you met Priscilla, Pat?
I don't know unless you're at the conference, Priscilla. Hi there.
Hi. So I'm filling in for Ozma today, so.
Sure.
Who is filling in for Shweta, so. So Shweta's on vacation, Pat. I don't know if you realize that. So I think that we got the slide deck up, but if we don't, I told Priscilla not to worry, that you and I are pretty proficient at this, so we can wing it. So.
Oh, yeah, no worries. Yeah, the slides are up.
Yeah. So,
So
Pat,
what did you say about Shweta?
She's on vacation.
Yeah, I saw that. I'm glad for her. She deserves to have some time off, huh?
I know. I'm telling you, Pat, we are so blessed with great support staff between Shweta and Priscilla and Ozma, and they deserve their time off so bad.
I know,
They work really hard. But I wanted to ask you a question. Did you see the email I just sent you?
No.
Okay, I just sent you an email now, and it is two questions that came from one of the hospitals, one of the Providence hospitals. And so when I get to the slide where I introduce you, I thought I would introduce you, and then I'll say that there's two questions, and I'll read the first question. Maybe we can talk about it. The first one was on,
Oh, I see.
do you see it? Yeah, okay.
They have a right to say no.
Pardon me?
These patients have a right to say no.
Right.
They have a right to say no as long as they understand the consequence of that choice.
Right. And what I've been telling people, Pat, because I did respond to her, but I thought still, but that, this is a really good time, like you brought up before, to really work on the teach back, and
Right.
so if somebody says no, then help me understand why would we want to accompany you, and why are you at risk, and, so that. Great. And then our policy is place anyone at risk for falls on a bed alarm. Oh, I know.
Yeah, we don't want to do that. So, yeah, we know the answer to that. No problem.
Okay, great. All right. So I just wanted to give you a heads up on those two. So I'm getting very excited about our last webinar. I have four hospitals that have so far that are willing to share. And so I have developed a little format for them to, actually I could send it to you while I'm sitting here, for how to present, what their learnings were. And so I think it's going to be great. I'm really excited. So
great. Well, I'm going to make sure that my content section then is short. I'll keep it as quick as I can.
Right. That'd be great because let me work with you on this. So I think it all turned out good.
Yeah. Absolutely.
Yeah. All right. How is the weather there? It's been so hot here.
Well, it's probably not as hot here as it's been in other places. Today it's been in the 80s. In Philadelphia, it's 106. So what can I say?
Oh my gosh! Oh wow!
Yeah, because we've got the Gulf breeze.
Right. Well, and I'm pretty close to the ocean, so that's true. But we're just not used to it being. It's been in the 80s, and I mean San Diego is like 70 all year round. So we're really spoiled. Oh, there's Teresa.
Hello there.
Hi, Teresa. How you doing?
Good, thank you.
Good. There was personally there was a glitch on the email, but I sent it out to everybody that was registered for the. I sent them the dial-in and the connection. So hopefully, I'm just surprised nobody's on yet. They're usually just waiting on us, right, Pat?
They are, yeah.
Did you see that little template I sent you, Pat?
Oh, let me get back to email to another section here. Okay, let me just see here. Yep, I just got it.
So I thought, just the first would be who they are, and then second slide is what they did. And then third, if they have any, because a couple of the hospitals I've been to have specific tools that they're using so they could put that in there, and then thank you.
Yeah, and
good?
well, On slide number 2, you could add the third one, which would be, do you have any outcomes yet to share? You know, and it could be structure, process, or outcomes. Any changes in structure, process, or outcomes that you'd like to share.
Okay, great.
So yeah, number 2 is fall prevention processes. But if they have any outcomes, that would be great too.
Okay.
Well, my boys just came in to sit with me. Got Jethro, Oreo, and Mr. Goober right here. Thanks for doing that, Martha.
Yeah, no, thank you. That's great. That's excellent. And I did, my plan too was to pull the one of our recent fall data graphs and see, you know, if we've made any impact there. So.
Oh, wonderful.
Yeah. Actually, I was even thinking I'm going to try and see if I could do a comparison of the hospitals that have been attending the webinar series. I think I'll go ahead and get started.
Conference recording started.
Greetings. This is Martha Ackman from the Hospital Quality Institute, one of the clinical improvement advisors working on the HEN 2.0 project. I want to welcome you all here today. I know that I'm sure everybody has really busy schedules, and we just really appreciate you taking your time to participate in this, our 4th coaching webinar series call. As I said, it's great to have each of you on the line, and it's been so fabulous to hear from Pat Quigley, our subject matter expert, as she's guiding us as we strive to eliminate harm from falls throughout the state of California. Just a reminder that the CEUs have been approved for BRN, CPHQ, and ACHI. To receive credit, you'll need to complete the webinar evaluation link in the web links box to the left at the bottom of the screen. Be sure to give us your full name, email address, and license number in the evaluation to receive the credit. Also remember that lines are not muted, so please mute your line. Don't put us on hold because we will then get your hospital recording, your welcome recording for people that are on hold. So I would like to just also remind you to please chat in your name and organization so that we're sure that we have that when we do the CEUs. We do a cross-check. And there will be a recording available in the next 3 to 5 days. So again, this is Martha Ackman, and we're going to get started. Our first question is really the polling question, and that is, who is in the room? Priscilla is helping us out today with the polling question, so are we able to put that up there, Priscilla?
Unfortunately, it's not working on my end, Martha.
Okay, so this is a question that we've had most of the time, and pretty much, so I guess I would just ask you, well, I can't see the questions either. All right, why don't you just chat in, please, who you are, where you're from. Are you a frontline staff member or leadership? Oh, here it comes. You got it, Priscilla.
Yeah, I see it working. This is Pat.
So you can just check whatever. So we can see that a fair amount of the participants are either in management or other. So if you're in the other category, if you just chat in where you're from, that way we'll have an idea of who's who. Our next slide then is just to review our objectives. Our objectives with the webinar series is really to extend the application of fall and fall injury prevention interventions to specific populations, to restate the critical program elements to reduce repeat falls and preventable falls, and 3, to compose strategies to reduce barriers and enhance facilitators to short-term and long-term program implementation. Just a reminder that,
hello?
Yes?
Hi, I apologize. I am unable to see the PowerPoint for whatever reason. I can't log in. I can listen in. Is there anybody that can maybe email me the presentation? Is that possible?
Yes,
If not, I can listen in.
We can forward you the link. Could you just type in who is whoever that was?
Well, I clicked on the webinar, but I couldn't. It doesn't allow me. I guess I don't. This computer I'm sitting in does not even have the program, so I can't even get on there to log in. I just logged in to put my name.
Okay, so you want us to send you the slides?
Yeah, that would be great, if possible.
But I
if
don't
not,
know.
I could just listen.
I don't.
Sure, I can give that to you.
So if you could just email it to me, I'd be happy to send it to you.
Okay, I'll do that.
Great.
Thank you.
It's mackman@hqinstitute.org. Okay, so those are our objectives, and just like that, this is an interactive live program. So if you have any questions, feel free to stop Pat or I as we go along. We're happy to take questions. So we know the series began with an in-person fall workshop in April of this year, both in Northern California and Southern California. Not necessarily all of you attended the in-person workshop, so we also augmented that with this webinar series. The first webinar was May 26th and focused on the post-fall huddle and patient engagement. That was followed by the second webinar on June 13th that looked at strategy to protect patients from injury and engage frontline staff as unit champions. And last time on July 5th, our third webinar discussed some of the challenges related to toileting. Today's webinar will focus on mobility issues and postural hypotension. So can we bring up the next polling question, please? Oh, great. Here we go. So does your mobility assessment include gait evaluation, transfer evaluation, lying to sitting status, ability to lift legs on and off the bed, sensory neuropathy, and proprioception? And these are things that we will be talking about, or Pat will be talking about during the webinar today. So if you want, you could check that. So we have a couple that are using the gait evaluation and the ability to lift the legs off the bed. Give you one more minute to, or anyone else? Transfer evaluation. Okay, let's go ahead and close that poll. We can see the majority, or that quite a few people are using the gait evaluation. That's great. Transfer evaluation and ability to lift legs on and off the bed are being evaluated by some of the participants. So Pat has some good information she's going to share with us today in these categories. The next polling question, could we please open the next polling question? And that is, do you assess your older adult patients or those with hypertension for postural hypotension on admission, postural hypotension after change in hypertensive meds, or routinely for patients admitted on mental health units? So again, I would ask you to go ahead and answer that with the polling questionnaire. We have a few more, 30 more seconds. And we can see here that a few hospitals are doing the postural hypotension after change in hypertensive meds, and I know Pat's going to be talking about that today and discussing the proper way to do a postural hypotension, to measure postural hypotension. And then I'm very happy to see that a couple units that are having mental health patients, that they routinely do postural hypotension on those patients. And we know that that's important because we know that those medications can affect the patient's blood pressure. Okay, so that being said, I want to introduce our subject matter expert, Pat Quigley, who's been with us from the beginning. Thank you so much, Pat. She is an Associate Chief of Nursing Research and funded researcher with the Research Center of Excellence. Her contributions to patient safety, nursing, and rehab are evident at a national level, with emphasis on clinical practice innovations designed to promote elders' independence and safety. She's known for her program of research in patient safety, and particularly in fall prevention. The Falls Program research agenda continues to drive research efforts across health services and rehab researchers. I would like to, Pat, as you get started today, I have two questions I want to share with you. So that came from one of our participants last time. So the first question was, we have a very diverse patient population at our community hospital. The staff are saying, especially the Hispanic and Armenian males, are refusing to have someone stay in attendance with toileting issues. The thought is that there is a cultural component to their refusal to allow assistance, even though they are a high fall risk. Any thoughts on how to address this issue?
Oh, Martha, it's so great to hear your voice and to be with you on this fourth webinar. And thank you so much for the warm introduction and bringing this question forward, because I just love being able to talk about this concern, because across all settings of care with the adult population, I think irrespective of the ethnicity, we face this. You know, those people who we think are at high fall risk, and males who, you know, overestimate their abilities and think that they can't do things. And this is associated with toileting and not wanting to have someone be with them when they go to the bathroom. So I think that this is a really important question, because I think this really helps us to all come back to that whole one of those interventions we talked about a couple webinars ago, and that's the teach back strategy and focusing on autonomy, because people have a right to make a decision. So whether it's a woman or a man, irrespective of ethnicity, for people who are cognitively alert, what we want to do is to let them know that they can make choices. And those choices can either be related to a call bell or can be related to having someone be with them when they're toileting. But the choice can be either yes or no. So if someone is telling us that they don't want to have someone with them, then what we need to do is to make sure they understand the consequence of that choice if an accident was to happen. And that accident could be a fall, and what could happen if they have the fall. So I think that that's really a wonderful way to approach it. If they can do the teach back, if they can tell us what happens if they choose not to have someone stay with them, just like what happens if they choose to not use a call light for help, if they can tell us that back, not just one time after just teaching them, but when you come back and ask them again, 8 hours, 12 hours, 24 hours later, make sure that they really remembered that and they understood that choice. They say it repeatedly, then that's their choice to make, and they have a right to make that choice. So I think, trying to deal with them, it's our responsibility to make sure we help them discuss all choices that they can make, in this case, the choice for no, and that they understand the consequence, and we've really done what's our role in terms of self-determination and autonomy. But make sure you document that. So that would be the response that I would give to those colleagues who asked that question, Martha.
I think that's great, Pat, and I think even underscoring that, the other thing why we really want to ensure that the patient understands their risk is the patient's going to leave our care. So they're going to go home. So we want to be sure, we tend to really, take care of the patient while they're in the hospital. So we really need to know that the patient understands why they're at a fall risk and what happens when they don't have the proper help. So,
well, the other thing too, I think that really resonates, Martha, is that people can be much safer in their home environment. Our environment where they come into our care is a different setting of care. They've got other risk factors, and they wake up in an environment that they're going to be maybe a little bit disoriented, and it's just not the same bathroom setup. So when people are saying that they're refusing to have someone stay with them with toileting issues, we need to evaluate, can they safely get on and off of a toilet? And I think we talked about that in the toileting session is, how many of us really orient someone to the bathroom to see if they can safely get on and off a toilet? So that should be even part of what we're talking about today. In terms of mobility and gait assessment, we should know whether or not they're safe in the bathroom. So that should be part of our assessment. But acknowledging that, people, and helping them to know, too, that maybe they're on some medications they haven't taken before, help them know why they are going to be in the position of overestimating their abilities, because there's things that they're going to be going through they haven't done before. But you're absolutely right. No one has 24/7 care around them at home like we have in a hospital. That's why falls are rarer in hospitals than they are at home. They fall more often at home, inside, outside. But I think that's absolutely correct, and thank you so much for adding that.
So, and Pat, there was one other question that came through after our last webinar, and that was, our policy is to place anyone at risk for falls on a bed alarm. We have alert and oriented patients that are at high fall risk, and they are refusing to allow the bed alarm. Once the nurse has carefully explained the benefits, risks, and possible consequences of a fall, is there anything further to do beyond documentation of the informed consent?
Well, I think that this comes back to just as you were saying, we should not be implementing interventions on people simply because they're high fall risk. But quite honestly, everybody is high fall risk to be in a hospital. So what we want to do is to maybe come back and evaluate ourselves. What criteria are we using for selecting bed alarm use on a patient? And those criteria maybe should be reduced to those people who are cognitively impaired, maybe impulsive, and try and get up out of bed and can get up out of bed, to be more selective than and have more precision in the need for an intervention than just by saying someone that's at high fall risk. So for people we're trying to talk them into it, which is what I hear, even though we've gone ahead and reevaluated our selection criteria, what we want to do is to help them know that this is a gentle reminder, but maybe offer them a different type of alarm. Because in putting a bed alarm on someone, people should hear what it's like before it actually gets implemented and you just walk away. People should hear, what's the alarm going to be like? How does it sound? To help us be able to notify us that you're starting to get up. That's what we want to do. And maybe even people who are cognitively alert, high fall risk, and partially sedated after a special procedure, that they would appreciate why it's important for us to know that they're starting to get up or changing positions close to the edge of the bed. So I think that there's some other things that we could talk to them about, but I would come back and reevaluate the practice of just putting everyone on a bed alarm just because they're high fall risk.
Excellent point. Excellent point, Pat, and very timely because we know that alarm fatigue is really a critical issue. And as you pointed out many times, the alarm with falls is, it's post fact, when people get there. So thank you.
Sure, and for some patients, an alarm, even people with cognitive impairment, it can be frightening. They don't know what this noise is. They could think it's a fire alarm. So you still have to reconsider. Not one piece of equipment works for all patients.
So let's let you take it away here, Pat, and talk about the mobility issues and the postural hypotension.
Thank you so much, Martha. And we're so glad to have so many of you with us today.
I know.
Really
Isn't it
just
great?
a treat to be together again. And we had so much content in this session that we actually split it between this webinar and our last webinar that we get to be together again on August the 15th. So this is something that people talked about when we were having our group discussion about things that they thought that they wanted to change, things that were going to take more time. And this whole issue of mobility and gait and balance and why we're talking about transfers and whether or not we need to have people in the room helps us to appreciate that all of us have fall risk factors and all of us are aging gracefully each and every day. So, I spend a lot of time focusing on the older patient population, even though we know people, middle-aged adults are falling, even younger, and certainly kids. We spent so much of our time talking about older adults. But we know that as we age, our risk of falling for those anticipated physiological falls increases because of normal aging. As we age gracefully each and every day, what can happen is that we have to evaluate our balance because remember, balance is a function of the combination of vision, balance, and sensory systems. So as those change, we can have issues surrounding our balance, and that's why it's important to be able to include that bit of balance assessment when you're evaluating patients when they come in. And you can see an awful lot just when you watch someone walk into a room or trying to do some transfers or how they sit and maintain their balance in a sitting position. Do they maintain their verticality? We have increased postural instability due to changes in our inner ear. We can have increased sway. And anybody who's had vertigo certainly appreciates what this is. And there's exercises that can be done to help people when they have vertigo to be able to evaluate this. And, it's a very different symptom when people have that sense of vertigo. The dizziness is associated with vertigo because what they see and experience is the whole room spinning. That is very different than someone who's starting to faint, if you will. So when you know that people are having problems with inner ear decrease and increasing sway or having issues with vertigo, that would be the kind of dizziness that's associated when someone's in a lying position, they're turning their head, and they start to feel the room swaying. So this can happen as well. And then we have awareness of a body position, and feedback will decrease and interferes with our proper foot placement. So this can happen certainly when we have problems with sensory neuropathy or impaired proprioception, which are two of the questions that we wanted to ask when you're actually doing some of your evaluations when people come into your care. So we all are aging gracefully, and in addition to that, we can have our posture that's changing because we have a wider base. And you will see wider bases in people who are walking that have increased weight, the obesity issues that they have a wider base, or indeed if they have sensory neuropathy and they're trying to compensate for their loss of sensation. You may have people who have shorter steps. Their foot placement is not as long as it should be. It's shorter, and they have decreased velocity, so they kind of slow down. They have decreased steppage height, how well they're able to lift their feet. And when you see that, what you will oftentimes see is that these are people who are starting to shuffle, or they might even have some trouble with toe clearance. And they have decreased arm swing. And with decreased arm swing, they're not as able to be able to keep their center of gravity. So you can tell an awful lot when you watch people walk. And then with vision, of course, they have changes with increased sensitivity to glare and adaptation. You will see this oftentimes with people with glaucoma. Macular degeneration there's issues with as well. So they have increased risk factors that are many. There's intrinsic risk factors and extrinsic risk factors. So when you think about the aging population, you want to be able to do a multifactorial risk assessment as people are aging to be able to evaluate how they're walking, how they're transferring, what their gait is. So we know that that one of the common risk factors associated with aging is people who have dementia and depression. And then, of course, delirium. So there's cognitive impairment that we have to be able to evaluate, whether or not they've had a previous fall. And many of us have talked about the questions surrounding previous falls. It's not just a yes or no question. If someone says yes to a fall that they've had in their history, you want to ask about the falls. What's going on? What are the circumstances of the falls? How many falls have they had in whatever the interval is that you're asking? Are you asking in a 3-month interval or you're asking in a 6-month interval? But you want to ask about those previous falls, and you have to learn about them. And you want to know if they have fear of falling. And we haven't spent much time talking about that, but fear of falling, there's a whole construct around this. There's a tool that actually evaluates fall self-efficacy, and that's their confidence and their ability to be able to manage a fall or be able to prevent a fall, but to manage a fall if it was to occur. So fear of falling has a range of what can occur. They can have a range from mild fear of falling where they're protective and they're cautious, or they can have a severe fear of falling where they become socially isolated and stop doing things. So they are really severely impaired because of their fear of falling. They will become deconditioned. They will become, as I mentioned, self-isolated. But that whole cycle of becoming deconditioned, not willing to go out, becomes very, very destructive. And that, of course, increases their weakness, loss of balance. So you can just hear even how fear can affect their physical ability to be able to maintain and reduce their fall risk factors. Fear of falling can contribute to their risk of falling. So that is an important intrinsic risk factor that rarely do people ask about when they're talking to older patients. You know, when I ran my falls clinic for so many years, from 1999 to 2016, one of the questions that we would ask our veterans coming into our care, to our falls clinic, is, do you have any concerns about falls? And do these concerns limit your willingness to go outside and engage in activities? So there's ways to be able to ask that without, if you think that someone isn't going to tell you they're afraid, to be able to get to this and eventually get to this whole issue of fear of falling. Of course, there can be cardiac arrhythmias, transient ischemic attacks, and stroke. The cardiac arrhythmias, the atrial fibrillations, putting people on Coumadin, but this can all affect their risk for falling, of course, and the medications that are associated with it. Parkinson's disease, I know we've talked about. These are people who have can freeze while they're walking. They have that shuffling gait. They have the rigidity that occurs. So what are we doing when we're trying to help with fall prevention from them? There's so many other diagnoses that we could talk about, but that should be a red flag, because these patients, even if they might not have Parkinson's disease, there are patients who come into our care that have Parkinsonian symptoms. But they do have a little bit of tremor that's unintentional. They can have still that shuffling gait that is occurring. So just even being able to do this kind of assessment is really important. And then any kind of subacute or acute medical illnesses can contribute to their risk of falling and the medications associated with that. And then orthostatic hypotension, dehydration, and hypoglycemia. So for orthostatic hypotension, which we will continue to spend time on, it is important for people to be assessing for postural hypotension. And I saw in the polling questions that many of you are doing this upon change in admission, or a couple people on mental health. But this is an important and known risk factor that's in all of the literature for older people. So we really do want to find ways to be able to integrate this into our practice, because it's a known intrinsic risk factor. And then when people are dehydrated, becoming dehydrated can also affect hypotension. So this is really important. And with people who are diabetic, their risk of falling is great when they're hypoglycemic, not when they're hyperglycemic. So I always say for older people, it's better to let them eat than it is to keep them tightly controlled, You don't need to have a tightly controlled hemoglobin A1C in someone who's older. Well, it's not the same importance of controlling for hypoglycemia, or hyperglycemia for older people as it is for someone who's diabetic in their 20s. You're dealing with someone who's 80, 85 years old. Let them eat, because people who are hypoglycemic, that's when they fall. So the intrinsic risk factors are the intrinsic risk factors that are inherent to the person's body. It's inherent to the person. So you'll see on this slide, there's additional intrinsic risk factors, the musculoskeletal conditions, and these are the problems that are associated with gait and mobility. And these affect activities of daily living, their impairments and their inabilities to be able to do some of what they've normally been able to do. For example, getting on and off the toilet, like we were just talking about in the questions that Martha was introducing to us. But musculoskeletal conditions affect gait and balance and mobility, of course. So this is why we need to be able to do a musculoskeletal assessment. And so much of our patients' assessment when they would come into our falls clinic was neurological and musculoskeletal, and of course the vision component. So these are, and people get deconditioned. No one loses anything as fast as they lose strength when people are sick or when they're bedridden or, when they just become sedentary. And as they get older and they spend more time sitting than they may be being engaged in activities. And certainly incontinence we all know that that's a known risk factor, both bowel and bladder. The changes in vision, as we were mentioning, or auditory impairment. And then sensory impairments. If people cannot feel where their big toe is when their eyes are closed, that can affect their balance. And that's why it's really important to get to proprioception. Proprioception is if they're able to self-correct and if their reflexes will work and help with writing when they start to lose their balance. So it's not just proprioception, but it's also being able to feel their lower extremities. And you know what? All of us who take care of patients who are diabetic, we all learned to assess what symmetrically in the lower extremities if people can feel pressure, light pressure upon when their eyes are closed, upon implementing that pressure as you symmetrically go on both sides of the leg with both extremities. So sensory impairments can affect someone's gait and balance. They don't know where their feet are, or they don't have that sense, that riding ability. And of course, their vestibular dysfunction. If people have foot problems, foot pain, it affects their gait. And certainly people with dorsiflexion, ankle dorsiflexion, are going to go ahead and have trouble being able to clear their feet. They're even going to have trouble with heel strike when you're looking at their ability to safely be able to walk. So these intrinsic risk factors, as we'll go back onto these slides, the intrinsic risk factors, I think as we just mentioned these, it helps you to really think about what kind of an assessment are we really doing when patients come into our care? Is it comprehensive assessment, which is what we really need to have? Now, colleagues, the extrinsic risk factor, these are the risk factors that are outside of our person. So these are ones that are considered to be not inherent to our person, but they're inherent within our environment. So we all know about the literature that dates back to 1999, the groundbreaking work of Lipstick and others that really showcased the effect of polymedicine, polypharmacy in increasing the risk of falls associated with medications in older adults. And you know what? Polypharmacy is very different than polymedicine. Polypharmacy is when people are going from one provider to another and they're getting all these medications. But still, 4 or more is considered to be the number. But, it's not, the polypharmacy is adding on medications without considering the need for other medications that someone is already on and managing their comorbidities. Polymedicine is the correct medications to be able to manage the comorbidities that people have. So this is, there's some diagnoses that people have where they need to have maybe 3 or 4 medications, people with congestive heart failure, people who are diabetic. So when you look at polymedicine, there can be patients who are on so many medications, but the question is then, are they on the right medication, the combination of medications, the right dose, short-acting, long-acting, to manage their comorbidities but still reduce their fall risk? And that's a very complex question. So medications indeed is a contributing factor for people falling. And one of the geriatricians that I've worked with for so many years, his name is Steve Castle. He's done a lot of work on medications and lots of presentations. And he always says, if you think about if a patient's on more than one medication, you know, there's nothing that's more modifiable for reducing fall risk than looking at changing and modifying their medication. So any medication we should think about as contributing to their fall risk, and then certainly looking at the combined effects of medications and how that confounds someone's increased risk of falling. But I think it's important to differentiate between polypharmacy and polymedicine, because people do go to different providers. And I know even in the VA, we have a lot of patients who would go to a private provider outside of the VA for managing their health care needs, but they would come to the VA for their medications because it was cheaper. But that doesn't mean that we would be able to actually manage their medications and still manage their comorbidities because they were going to an outside provider. So anything you can do to evaluate medications to reduce fall risk is essential. So this is why the no risk factor for fall is as potentially preventable or reversible as medication use. So that's what was so groundbreaking. So, you know, when you look at classes of medications, the benzos, the diuretics, the psychotropics, there's so many classes of medications that we know that these classes indeed increase the odds ratio of patients having a fall if they were to be on these medications. So we should be evaluating the medications and see if there's anything else we can do to be able to reduce their fall risk. Many of you have said that came to our conferences that you had pharmacists that you were working with to be able to look at these medications. And even with pharmacists, it's very complex knowledge. It's specialty practice in pharmacy to manage the geriatric patient population, comorbidities, and look at modifying their fall risk associated with medication. So just because you have a pharmacist doesn't mean that they have that complex knowledge in being able to make recommendations to the primary provider for that patient for reducing or changing those medications that would reduce or eliminate some of their fall risk factors associated with each and every one of these medications. I've shared with you one of our templates in the VA for patients. We use the Moore scale almost exclusively for secondary diagnosis, which is that second variable on the Moore scale. When nurse clicks on that, because everybody has more than one diagnosis as a veteran, but when they click on that fall risk factor, there's a whole list of classes of medications that will be, that when the template opens up, that will be listed there. So the nurses will look through those medications and then make a decision to make a referral to pharmacy to come and review those medications for the purposes of reducing fall risk. They make a recommendation, as I mentioned, to the prescribing provider. So we just have just a few medication lists here, but I have published a series of articles in this with my colleagues at my Patient Safety Center that helps really go over many classes of medications that can contribute to fall risk, but it's very complex. So here are some other extrinsic risk factors. The use of restraints, of course, and if you're using restraints, and you know, there is even some people who have considered bed alarms to be a restraint. It doesn't restrict their mobility, but if it was to be used in that way for fall prevention, where it's in association with side rails, then you have to consider, is this moving into that direction? But even side rails can be considered a restraint. Clearly, in long-term care, they are restraint-free, and that includes side rail-free. The only time a side rail could be put up in long-term care and not be considered a restraint is if the resident can go ahead and actually lower and raise back up that side rail. And some of that discussion lends towards the hospital setting, because in the hospital setting, oftentimes what I will see when I do rounds, and maybe this is in your policy, is that you allow 3 side rails with 1 area open. But if those side rails are used to prevent falls, then those side rails are being used to restrict movement. And if they're being used to restrict movement, that's when you start moving into the domain of restraint. So we really don't want to have side rails up, because we know from the literature that goes back to the 1980s, the great work of Liz Capizzuti, that if patients fall with side rails up, their risk of injury is much greater. So consider this whole issue surrounding restraints. And then, of course, all those environmental factors, the dim lighting, the glare, inappropriate footwear. And what might be an example of inappropriate footwear that we've talked about before is having patients wearing non-skid socks on a patient who has Parkinson's. You know, we don't want to put non-skid socks on someone with a shuffling gait, or a patient who has that drop foot, a stroke patient, for example. You could have uneven flooring, and look at the transition from going from the room, the patient room, into the shower, into the bathroom. sometimes some of those door sills are essentially a step up. And can people actually clear that? Certainly, you have to evaluate that if they're walking with a walker or some mobility aid. Any kind of loose rugs, we know that that's an issue. And we don't have a lot of loose rugs, of course, in hospitals. Maybe some of the entrances in and out of hospitals, but sometimes you'll see those in a long-term care setting, certainly in the home environment. But, an example of too much stuff on the floor could be in showers and patients' bathrooms where people are putting all these towels down to keep the floor dry and prevent the water from flooding out into the actual bathroom. So you want to look at anything that's loose on the floor that people could potentially slip on, get their foot caught up in. Certainly what environments are an issue, slippery floors as you see here, or old and unstable furniture. And sometimes unstable furniture can be that bedside commode that people are using. So you need to look at all these environmental risk factors. There's so many environmental risk factors inherent in our setting of care that we don't always change or eliminate when we could, if we could just replace it with a better piece of equipment. It could even be your chairs, chairs that don't have armrests that we need to replace and put in the room, a chair that has the proper height, a chair that has like a captain's chair that has a backing, and then has armrests so people can safely sit down and get up. So the whole issue of furniture is really important. Just like low beds, not everybody should be in a low bed. So it's imperative for all of us to be able to assess these risk factors and evaluate someone's ability to be able to navigate and be able to do transfers, get in and out of a bed, get in and out of a chair, be able to get to a bathroom, on and off of a toilet, evaluate their interaction within the environment. So remember, colleagues, the extrinsic risk factors are the risk factors that are associated with patients who within their environment, and how well do we evaluate their interaction within their environment. So this leads us to the connection between safe patient handling and movement and falls. And there's been a lot of work done over the years, of course, for preventing back injuries in the nursing staff, the whole safe patient handling and mobility work at the point of care. And the intent of safe patient handling and mobility is to make sure that we maximize someone's ability to safely get up out of bed, to be able to do the transfer, to ambulate, but that we select equipment based on their ability to assist or inability to be able to assist with whatever mobility activity that we're doing. And that's the patient handling component. The patient handling, you do want to evaluate their bed mobility. So when we evaluate bed mobility, colleagues, this is asking about some of those polling questions that we had in the very beginning, is to evaluate how easily someone can get from a lying position to a sitting position. And can they get their legs easily on and off of a bed? And making sure that patients are transferring towards their correct side, that that right CVA patient is not transferring towards their left side of the bed, because we don't ever want them getting up towards their hemiparetic side. So you want to be able to evaluate if from lying to sitting, if they get to a sitting position, can they maintain that sitting position? You don't want people, again, getting up towards their hemiparetic side, or if they're a brand new amputee, getting up towards the side that had their surgery. You want them transferring towards their intact side, the intact leg side, if you will. So you want to evaluate bed mobility, transfers, toileting, and gait. And then, of course, the ADL task. How well are they able to transfer on and off their toilet? How do they actually manage their dressing, getting their clothes and dressing? I cannot tell you on a rehab unit how common it is for patients to fall trying to get up out of bed to go get their clothing because they don't want to wait and someone hasn't put it down and they didn't have their walker within reach. Can they reach for something, if they're toileting, to be able to clean and wipe themselves, and then the dressing, grooming, and bathing. So you select the different kinds of equipment that's needed based on this. So there's lots of opportunity to be able to integrate the evaluation that's already inherent in safe patient handling and movement, to consider that when you're helping with fall prevention. So in safe patient handling and movement, we all know that there's many barriers to be able to prevent an injury. Every one of that Swiss cheese model, slice of Swiss cheese, is a barrier to protect something from happening. And we have, as we age, we talked about normal aging, how we know how our Swiss cheese can just kind of get holier as we age gracefully. Well, as our Swiss cheese and our slices become more holy, They become more porous, if you will. There's more opportunities for a fall to occur. So in this case, for someone to have a patient handling injury, you can have protective barriers that fall through where, someone indeed gets injured. So on a medical surgical unit, we've been teaching people for years how to do a mobility assessment of a patient. And it has to be completed, but if it's not completed according to policy, then there could be something that occurs, something that gets missed. You could have a friction-related device that isn't returned back from laundry on time, a special kind of sling or a device that's used for that patient, and we're going ahead and we're going to decide just to go ahead and do a manual transfer because we don't have that device. You could have staff that are in a hurry and do not reinforce the need for that mobility assessment, and they don't use that friction-related reducing device when it's really to help them with repositioning a patient. So you want to be able to make sure that people have the equipment that they need to have so that they can protect themselves. Otherwise, you can have an employee that ends up sustaining a lumbar injury. They go on light duty. They're on back injury prevention, light duty work, and then they need to have medical interventions. And we don't want to have that happen. We want to do everything we can to be able to protect people. So just if you look at all of this, it all begins with a mobility assessment with the patient. So that's what we want to do in fall prevention as well. Because in fall prevention, there's so many fall risk factors. And many of our patients are living with these fall risk factors, so many of them. And how do we really evaluate what are we doing to prevent every one of these fall risk factors or be able to mitigate or eliminating them? And that's why alone universal fall precautions doesn't work. So you want to do that fall risk assessment with the patient and make sure it gets completed. And you do a mobility assessment, a gait assessment. You want to be able to assess for postural hypotension and do it right, not just when people are symptomatic, but include that in your admission assessment, making sure that you check blood pressure and pulse after lying in a lying position supine for 5 minutes, have them immediately stand up, check it again, blood pressure and pulse. The clock starts as soon as they stand up, and you've got to keep them standing and assess it again 3 minutes after standing to see how much the blood pressure drops and whether or not the pulse elevated to compensate for that blood pressure that's dropping. And we look for a drop of blood pressure, 20 millimeters of mercury systolic or 10 diastolic. Either of those is indicative of postural hypotension. And then you ask if someone's blood pressure is dropping, whether or not they're symptomatic. So we have to be able to do this. If someone has impaired gait and balance, they should have their walker within reach. If it's not, and they've been using a walker at home and that they're safe with their walker, they should have a walker. We should have those available in our unit to make sure that if this is what someone uses, that they have that available and within reach, because we know people are going to get up without us. We don't want people getting up without us. If they do get up without us, we want them to be safer. And the way that they're safer is if they have their mobility devices that they've been using within reach. So you want to always be able to do that. So you want to manage and reduce risk. And the way you manage and reduce risk that's associated with mobility, postural hypotension, is to make sure that you're doing a screening and assessment. You want to check that off. And this is not just the screening. You want to move from a positive screen to actually doing an assessment. If someone cannot get their legs on and off the bed safely, then we need to be able to assess what's going on with their muscle strength. If they're not able to maintain their sitting balance, then you know they're not going to be able to maintain their standing balance. So you need to be able to do slide board transfers and pivot transfers towards their unaffected side, their stronger side. There's so much that gets done with every aspect of your assessment, but you have to do assessment. You just can't do a screen. And then on the environment, you want to be able to look at how to increase the infrastructure and capacity to reduce any kind of fall risk factors associated with their environment. There's some things you can change today. There's some things that take more time. Like getting you can order a raised toilet seat and have it put on the toilet without having to have everybody on the bedside commode. But to actually replace toilets with higher toilets takes more time, for example. So, but there are things you can act upon. But consider the interaction both between cognitive and mobility function. Because with cognitive patients, you can still teach them how to do safe transfers, how to be able to exercise safety if everybody teaches them the same way, the same thing the same way. You can increase their safety, but there has to be continuity of care. If you don't have continuity of care, then you have trouble with them being able to learn from you. But people with cognitive impairment can learn if everybody does things the same way. And then, as we mentioned in the beginning with the questions that Martha was posing, is the whole role of autonomy, because people want to be safe. You know, no one wants to fall, and when people fall, everybody's embarrassed. I don't know a single person who isn't embarrassed and feels awful about it and remembers it, except for older people, because for older people, falls become more common. But they still have to have choice, and that's what we really want to exercise. So today, we have gone over normal aging. I think that this is just the beginning when you consider what happens as we age gracefully, and why it's so important for us to be able to engage in exercise, knowing that exercise still can increase the risk of falling because you increase exposure to other activity. And we've talked about the intrinsic and the extrinsic risk factors. And colleagues, as we mentioned with these intrinsic risk factors, for all of these that are here, it requires a comprehensive assessment. And remember, to be able to reduce the intrinsic risk factors, this is when you're reducing the risk of an anticipated physiological fall. If anyone falls because of these risk factors here, that would be an anticipated physiological fall. Remember, you're going after reducing the two types of falls that are preventable, anticipated physiological falls and accidental falls. So the intrinsic risk factors are associated with the anticipated physiological fall. That's why we have to do a comprehensive assessment. The extrinsic risk factors here that you see on these slides, when you do the extrinsic risk factor, as we had mentioned some others before, this is when you're reducing the risk of the accidental fall. So we always remember that the interventions to reduce an anticipated physiological fall are separate and distinct from the interventions to reduce an accidental fall. You always want to align the intervention to the type of fall that you're going after so that you have some precision and you can know what have you really done to be able to reduce risk. Risk in the environment, risk with the patient, and then risk within the interaction between the patient within their environment. So as I mentioned briefly, the postural hypotension is a known risk factor in older adults. And you have here on this slide on the how to be able to measure the signs and symptoms of postural hypotension. And this is a symptom, this is a known fall risk factor that everybody should be assessing the same way. But let me say to you that what we're presenting here is the way to measure postural hypotension in people who are normal tensive. So it becomes very complex when you start getting into other issues surrounding blood pressure. Like for someone who normally runs low like me, it gets to be a little bit different in how you evaluate it. But this is for people who are normal tensive. So you're looking to see if they have a drop of systolic blood pressure, as I mentioned, 20 millimeters of mercury or 10 diastolic. And you've got the measurements. You have to have three times of measurement, so you have to do repeat measurements. You do not do lying to sitting unless someone cannot stand. You want to do lying to standing and then repeat measurement upon standing, but you have to keep them standing. So on admission, when you're assessing this for someone, you might want to have someone stand with you during this test. But it is a test to see whether or not someone's blood pressure drops, and if their blood pressure is dropping, what's happening with their pulse, if it's compensating, and whether or not someone is symptomatic. In mental health, it does become sometimes difficult to get this done. If someone's really hyper, they're agitated, they're manic, but you do the best you can. But in mental health, so many of the medications that they're on indeed have a postural hypotension as a side effect. On telemetry, patients who come in with cardiac disease and they're on telemetry, the patient should be assessed for postural hypotension before they get started walking. People who are closed off, oh my gosh, people need to check to see if they're orthostatic before they start walking them. New mothers need to be assessed. So there's many populations that are out there. So as we had talked about, there's so many medications that can contribute to postural hypotension because of the side effects. So that's one of the things that I ask pharmacists to talk about and really refresh nurses with, is to help nurses know, for patients that I'm taking care of, what medications is this patient taking that postural hypotension is a known side effect for, so that I remember this, and if there's any change in that medication, I know to recheck for postural hypotension. But on admission, if someone doesn't have postural hypotension, then what you really want to do is that you don't have to keep doing it, but if they have a change in medications, then indeed you want to do that. So remember we talked about these other extrinsic risk factors, as I had mentioned, that these would, if you make any changes here that reduces their risk, or if they fall because of this, then this would be associated with an accidental fall. So there's so many things that in our environment that contribute to the risk of someone falling. As you can see, you know, chairs that have that don't have proper armrests, cords that are there, trouble with vision, these little steps that you'll see, little step ladders, oh my gosh. The stairs that have improper grab bars, the one with the bed, if someone was to fall out of that bed and if they fell on the way down, what would they hit on the way down? I mean, and look at the bathroom. Look at those grab bars, totally inadequate in relationship to where the toilet is. But any of those grab bars that are horizontal on the wall away from the toilet are not going to help anybody. So there's so many things that we can do to be able to increase the safety within these environments that's really important. And some are modifiable, you know, as I mentioned, some you can fix quicker than others. So there should be a strategic plan to make the environment safer. So we'd like to hear from you now. If you, for those of you who did mention that you were doing the gait assessment, if you know, any of your experiences with mobility assessment, your assessment and modification, things that you've maybe changed because you have done your gait evaluations, that was something, and some of you mentioned that you did some evaluations of transferability and ability to lift legs on and off the bed. Sometimes we end up changing the room environment, you know, making sure that people get out of bed towards that safe side, which is one of our interventions, the safe exit side. So we'd love for you to share your experiences and then any plans you might have to enhance mobility, your mobility assessment, and experiences in assessing postural hypotension, anything that you've done. And the topics we have at the bottom of this, the toileting protocols, the post-fall huddles, patient engagement, and teach-back are things we've talked about before. So we always want to hear from you, even though we're here today on July the 25th, that, you know, since we started with these webinars, maybe there are some other things that you've done that haven't been a topic for today, but we'd still love to hear about. So we have about 5 minutes for you to be able to share with us. So anyone who'd like to share, I think the lines are open. And thank you, Phyllis, for helping us. So who would like to share? Is everybody still with me?
Oh, sorry, Pat. I was on mute. This is Martha. There, a great question came in in the chat box, and that is, do you have an example of a comprehensive assessment tool? You know, we've talked about it a lot, that, you know, the Morse is a risk identification, but we have to really take it one step further and really drill down and do further assessment with that patient. So I wonder, do you have any ideas or resources that you could share with us?
Well, you know, what we built into the Morse scale is that if someone has trouble with transfers or gait, that variable, then what is built into the Morse scale is that the nurses can consider sending a referral to physical therapy for physical therapy to come and do an evaluation. But the evaluation, you know, that could take a little bit more time. So there are some on the STEADY program. Well, that's for the CDC STEADY program has a couple of assessment tools that can be used, but it's more for the outpatient setting. But they've got chair sit-to-stand exercises that can be done to be able to evaluate, can someone get up out of a chair by themselves, you know, without using their arms to push off. That's something that can be done. But I think there's, you know, to be able to evaluate that, it's a matter of making sure people can, you want to assess for range of motion. It's not so much a tool that's out there, but going back to your musculoskeletal assessment class 101, where you learn for you evaluate range of motion and strength, you want to see if people can hold their leg up against gravity. If they were to do a straight leg raise and you push down on it, can they hold their leg up against gravity? You know, if you were to check for dorsiflexion strength and you're holding the bottom of their foot and you ask them to push against your hand, what kind of strength do they have in their feet? Those are all things that we learned in our assessment. So I don't necessarily have a tool for that, but there is, you know, musculoskeletal assessment protocols that are in place. If you were to go back and revisit that, Banner Health had a mobility assessment test that they were doing, and they were rolling it out in Banner Health. But essentially, it was helping to evaluate lying to sitting, sitting balance, and then standing balance. But what they did in that program with Banner Health is then they put people in categories, 1, 2, and 3, and they color-coded it, who needed to have assistance to standard transfer. And that's one approach and some of those things, but that was more turfing off some of the physical therapy assessment to the nursing staff. This is a little long-winded, I know, but I'm just not in favor of putting people into a category 1, 2, or 3 because people can have better skills in the morning when they're refreshed and have fatigue in the evening. And then they need more help with that, and they're no longer min-assist for transfers, and they're maybe now moderate assistive too. So I think that there's a lot of things that we have learned. If there's help that your nursing staff needs to have, then have physical therapy come on up and do some balance and transfer training with the nursing staff is what I suggest. And go over that, how to be able to do an assessment of transfer and assessment of standing skills is what I would suggest.
Great.
How about anybody else? Sure.
There was another question on are there any other interventions for adult patients on inpatient psychiatric units who want to be ambulatory? We do not have bed alarms on our units. We use bells and every 15-minute checks, and they're looking for something other than the orthostatic hypertension. Is there something else that they're missing or opportunity?
I think I might have missed the first part, and it was for doing what? A lot of times they're wandering. In psychiatry, people are wandering. So what you want to do in psychiatry is to make sure that their pant legs are not too long. I look at their clothing. A lot of times they've been reduced to these, these really long pant legs, and they put everybody in non-skid socks, which unfortunately is not very good for people with shuffling gait. But a lot of times they can be put into shoes that have Velcro closures, and then make sure that if they are wearing pajama pants, that the legs of their pants are tucked into their socks so that they're not walking on the end of the pant leg because they can slide on them. So I'm always looking at their clothing and making sure that their clothing is safe because they do a lot of wandering. And then still in mental health, you can use mobility aids with them as long as they have supervision. So for the geriatric psychiatry patient population, you still want to check for postural hypotension, absolutely. But, what you want to do is to make sure that if they do need to have a mobility device, that they can be part of their plan of care, but have people be able to walk them with supervision. So sometimes that means you have to increase staffing for that one patient who needs to have that kind of help. And then there's sometimes, too, in geriatric psychiatry that you can go ahead and use a height-adjustable bed. Now, you may pick up today that I haven't talked about gait belts. And there's some places that use gait belts, and they put a gait belt on everybody, and they put a gait belt in every room. And we can talk about the next time we're together, too. And
So, Pat, this is Martha, and we're a little we're just reached the 1 o'clock hour. So I'm sensitive to everyone's time. So I want to put out there for the group that if you have a question that we weren't able to address during this webinar, why don't you go ahead and type email me the question, and we will make sure to bring it up at the beginning of the webinar next time. Also,
that sounds great, and then I'll talk about the gait belts then too.
Right. And also, I wanted to remind everyone that the next webinar, August 15th is our last one. As Pat said, she's going to be talking a little bit more on mobility, but the big focus is going to be the sharing. And I've heard from quite a few sites that are willing to share their stories about what they've been able to do or what they're considering. And I also want to put the invite out there. If you are interested in sharing your story, please let us know, and I'd be happy to connect with you beforehand or your clinical improvement advisor. So this is Martha. I'm Martha Ackman, mackman at hqinstitute.org. Just reach out to me with your questions and or any ideas that you'd like to share in the next webinar. With that, I want to thank you, Pat. We really appreciate you're always a wealth of information, and
Thank you.
appreciate that, and want to just tell everyone to have a great day, and we will look forward to talking with you again on the 15th.
Thank you.
Thank you, Pat
Bye-bye,
and Martha.
everybody. Oh, thank you so much.
All right. Take care, and thanks.
Bye-bye.
For the tool.
Bye-bye.